get recording here. Oh, Nia, you have a question?
Yes. So do we need to just make the graphs based on the data, or do we need to wait for the other people?
No, just make it based upon what you've got. Just use what
Okay.
you've got there and go for it. If other folks send me stuff between now and then, I'm not gonna try to re-update the file because every time I do that, then it will change, and then everybody ends up with different. Might have downloaded the file at different points, and that makes my grading much trickier in some ways because then I can't figure out if you got different numbers than somebody else because you have a different version of the file with different people in it, or because you did something incorrectly. So no, what's
Okay.
posted is what we're going to go with, and we'll just do what we can to shame the rest of them in some way for all of this for not getting their stuff in. Okay,
Okay.
cool. All right. So we spent some time yesterday at the end of class talking about how we do what's called a health appraisal. Okay. And I had asked all of you to download the two screening questionnaires that were posted on Canvas, the PARQ and the health screening questionnaire, and to fill those two things out for class today. So how many of you guys have actually done those? I can see that John has like printed them and everything and is holding it there. Okay, awesome. So what I'm going to do is I'm going to pull up the lecture, okay? And we'll talk just very briefly about a couple of things and the necessity of this, kind of why doing this is important. And then we'll get to the place where we kind of go to each questionnaire and we'll walk through while we're asking those questions. And I want you to kind of pay attention to how you answered each one of those things. And then we'll talk our way through why the PAR-Q is probably misused by a lot of exercise facilities in some ways, and why it's only good for clearing us for certain kinds of exercise, and then why we need a more in-depth type of screening for for stuff that's going to be more vigorous and everything else. And then so I'll give you guys kind of credit for doing that, and then we'll do some group work on trying to do some risk stratification. Kind of I'll give you scenarios and you'll kind of walk through what these look like, and then we'll start talking about cardiovascular disease. That's going to be what our goal is today. I suppose I should put it on everybody's radar that I think we're going to have our next test on Friday, and so, or maybe I will release it on Thursday night, let you guys have until like noon or something on Friday. No, we'll probably do it. Was the way we did it last time work okay for almost all of you? Did y'all find that to be okay that I like gave it to you at like 1 and then you could turn it in by 5? Was that okay? I know we had some people that had some scheduling conflicts that we can deal with. So, okay. Because we need to get through cardiovascular disease and then diabetes, and we can be ready for the next test. So, all right. Let me share screen number 2. So, okay. So to just kind of formally walk through this, we talked about this yesterday, but I want to, again, kind of draw your attention to a couple of things just to reiterate, okay? Up until now in class, right, the big overarching theme has been exercise and physical activity is good. It's going to add years to your life. It's going to add quality to your life by reducing different kinds of chronic disease morbidities, okay? And then we also mentioned that exercise, though, while it's good for you when you do it very often, acutely during that single bout of exercise, especially when it's of vigorous intensity, so especially when it is resistance training, or especially when it is, kind of a brisk jog or above, it is also inherently risky. And so during that single bout of exercise of vigorous intensity, you're going to get an acute increase in the risk of having sudden cardiac arrest or what we're going to call a myocardial infarction, which is what we typically think of as a heart attack, okay? So you may have some sort of arrhythmia and there may be an impairment of cardiac conduction. So that can happen, which can then lead to kind of stoppages and things there, or you may have a heart attack. Okay, so We mentioned that yesterday. The vast majority of the things that are going to underlie all of this, okay? And this is why we're going to ask some of the questions that we ask on the screening questionnaires, is that people that have diagnosed cardiovascular disease, they have high blood pressure, they have elevated blood cholesterol levels, okay? They've previously had a heart attack of some sort. They have a valvular disease, something like that. If you've got a diagnosed cardiovascular disease, that certainly is going to raise your risk of these things. And then there's going to be a lot of people, typically in y'all's age group, that have what we call silent cardiovascular disease. And so silent means it's there, but you haven't had any symptoms. And because you haven't had any symptoms, you probably haven't been to the doctor to get things looked at or checked out to be able to diagnose it. But it is nonetheless there. And at some instances during exercise, that increase in cardiac output, that making the cardiac muscle have to work harder during exercise, is going to interact with that silent cardiovascular disease to cause some problems. Okay. All right. So this is just sort of a cartoon showing what we've got in the midst of all of those kinds of things. So when we do this health appraisal, okay, what we are trying to do, and I guess I should probably mention this at this point, we must, to cover our butts, okay, we should screen and do a health appraisal on everyone. I don't care who it is. I don't care what kind of an athlete you are, what sort of shape you're in. Everyone, okay, everyone should be screened prior to beginning a new bout of exercise, okay? Doesn't matter. Do not pass go. Do not collect $200. You need to be screened first. So if we're worried about an MI, we're worried about sudden cardiac arrest, we need to identify people who may have the characteristics that would put them at an increased risk of these things prior to doing any kind of things. And we do this by having people fill out questionnaires, then potentially based upon their answers on those questionnaires, having them go to a physician to get evaluated. And we can wave our hands about exactly how much the physicians know about these kinds of things, and if they actually know any more about your risk and those kinds of things than what you guys will at the end of this class or at the time you graduate with our major. But they certainly have more authority to kind of sign off on things. And then based upon the physician's evaluation, then you may need to have a stress test. We put the EKG electrodes on people. We have them exercise under conditions where we are monitoring them, and we look for some sort of manifestation or abnormality that might give us an indication that the person either has had or might have an MI or might have sudden cardiac arrest. Okay? All right, let me look in. Oh no, I don't know where the chat thing went. Where did the chat go? Since you guys asked a question.
Someone was just asking about where we submit the appraisal forms.
Oh, you don't need to submit the appraisal forms yet. Okay, we don't need to do those yet. Okay, I don't know why I can't see chat, but okay.
I actually have a question too.
Of course.
So for stress tests, so I know that we might use them for this purpose for health appraisal purposes and exercise and whatnot, but I remember my dad got a stress test and it wasn't for that, it was for something else, and that was how they figured out that he had a 98% blockage in one of his coronary arteries. But what are the other circumstances in which they might prescribe a stress test?
So as we will see as we move along today, it's going to depend, Emma. Sometimes when you reach a certain age, if you go to just have a physical done or something like that, then they may want to do a stress test on you just to kind of check you out. They typically will do one on my dad every 5 years or so, and they've been doing that since he was maybe in his 50s or thereabouts. And part of that may vary. It's difficult to say They are sometimes just part of a normal kind of cardiovascular workup. If you change jobs or something, and you want to get new like life insurance or something, they will sometimes want you to go and have those things done before they will approve you for a certain level, or kind of dollar amount of coverage. Um, I know that once we had our daughter and we wanted to up our life insurance coverage, that my wife and I both had to go get our physicians to sign off of and like have, we had to have blood work done and then look for some things that we hadn't had previously. And so for that exact reason, right, they're interested in, if we can figure out that you have a 98% blockage, then you're at a much, much, much higher risk of actually having a heart attack. And then the life insurance people will have to pay out then if you were to die, and then, those kinds of things. So it might depend. But it can at times just be sort of standard like practice, like going to get your eyes checked or something, if you have a physician that's interested in those kinds of things. So, Nia, you have a question?
Yes. So the Part Q forms and everything, you don't need those yet?
I don't need those yet.
Okay.
I don't need those yet. Okay. So when we do the health appraisal, all right, as you guys have seen the Part Q, you've seen the health screening questionnaire. If you've got those, I want you all to just kind of look at them, right, kind of sideways on your screen, or if you printed them out or something, like pull them up and look at them. What we're trying to get at, okay, there's a reason that we ask the questions on there that they ask. And the purpose is to, first and foremost, identify medical problems. It's going to just ask questions very, very straightforward, very directly. Do you have diagnosed cardiovascular disease? Do you have diagnosed, asthma, diabetes, chronic obstructive pulmonary disease? It asks, do you have like a heart, a lung, or a metabolic issue? Okay, that's going to tell us something. If for some reason you don't have those, then it's going to ask you questions about, are there characteristics about you, things like a family history of heart disease, that could potentially increase your risk. It's going to ask you about signs and symptoms. So signs and symptoms are things that happen that you can feel or that we can measure, in essence, that would be indicative that there is an underlying health problem. Okay, so a sign or a symptom is shortness of breath or dizziness. It also probably asks about something called angina pain, which angina pain is pain and sensations in sort of your left shoulder up into your left neck and into your arm. And angina pain is indicative of a person that is currently experiencing ischemia in their cardiac tissue. So they're probably actively having a myocardial infarct, and that's going to be a thing. So it's a sign or a symptom. Okay. In the absence of all of those things, we're going to ask about lifestyle behaviors. We're going to ask, do you smoke? Do you exercise, or are you sedentary? What is your blood pressure? What is your fasting blood glucose? We're going to ask about other things that are going to also potentially put you at a greater risk for having these kinds of things. And if we have any fitness test results, like something from a stress test, what is your VO2 max? What is your resting heart rate, et cetera? We can ask about those kinds of things if we need to as well. But the point is, we need to identify people that are going to be at a higher risk by asking certain questions about, do you have a disease? Maybe you don't know that you have a disease, but you experience signs and symptoms, particularly during exercise, that are indicative that you have this disease and you just don't know it. And then in the absence of those two things, we're going to ask questions about other lifestyle behavior-based things that you're doing or characteristics that you possess that would predispose you to being at a higher risk of eventually developing these things. Okay. And we're going to weight our way through all of that, where some of them are kind of more indicative of an acute problem or acute risk of a problem than others. We'll walk our way through that in sort of the coming slides. Okay. So I gave you two screening questionnaires. The first one is called the Part Q. Okay. The interesting thing about the Part Q is it's a Canadian form. We're not going to hold that against it. I like Canadians. We get beyond their wanting to wear their maple leaf flag everywhere so that they can be identified as Canadian and distinctly not American. We're not going to hold that against them. But the PARQ, and the important thing about this, and this is where people use the PARQ incorrectly, I have found. The PARQ is much shorter and it's much simpler. All the PARQ is really going to try to get at is, are you a person that is at a very high risk of having a myocardial infarct or cardiac arrest during exercise? Okay. And so because it doesn't ask some more in-depth questions, it really only should be used to screen someone to see if it is safe for them to begin light to moderate intensity exercise only. Okay. The PARQ is fine if you've previously been sedentary and you want to start a walking program, or you just want to start being a little bit more active, then the PARQ is fine. Light to moderate intensity. Okay. So really, if you're going to go to any sort of like workout facility and do weights or take some sort of class, all right, that is really anything above walking, or you want to jog or you want to bike, this is probably not sufficiently detailed enough for us to be very, very confident that we have screened you properly. Okay. But a lot of exercise facilities, they use the PARQ. It's short, it's easy, it's something. Okay. It's something, but it really is only indicated for light to moderate intensity activity. The other one that I gave you was the health screening questionnaire, was developed in conjunction between the American Heart Association and the American College of Sports Medicine. It's going to get information from you about your medical history. Do you have current medical conditions? Do you experience certain signs and symptoms of especially cardiovascular disease? It asks about risk factors, things like elevated blood cholesterol levels, things like smoking. It asks about your current physical activity and exercise habits. So how active are you, or are you sedentary? And then it also asks about, are you taking any sorts of medications and supplements? So over-the-counter medications that we need to know, as well as prescription medications that we need to know about. So this is a much more comprehensive evaluation of sort of, are you engaging in behaviors that might make you at a higher risk? Do you have a medical condition? And the medical condition and sign and symptoms portion are probably going to be captured generally in the PARQ. But the thing that makes this other one better is it's going to get at the risk factor, the physical activity, and your medication use. Okay. So when we do these, okay, I want to point this out right now. When we do these kinds of things, because a lot of times in the regular semester, I ask people to go and have like their friends or someone fill out some questionnaires, and we bring them back in class, and then you guys get in groups and swap them around and try to decide, sort of what risk stratification group we want to put your friends into. The information that is contained on both of these screening questionnaires is considered medical information. And because it's medical information, it is protected by a law that is called HIPAA. Okay. And the essence of HIPAA is that getting accurate information on these things, your medical information, we need you to be honest with us about all of this. And in order to try to make you feel more comfortable being completely honest with us about what you do, and then I have found in sort of college age students, especially about sort of risk factors and then medications, over-the-counter prescription or recreational drug use, that we need people to understand that you put stuff on here and that information is kept confidential. We do not share that information with other people. We try to basically, like if you come down to our lab to participate in an experiment, you never put your name on a health screening questionnaire. You get a number, and then we have like one like triple password protected file that links those two things, because it's really important to us that you be honest. And we need to know if you do cocaine or something like that, and we're going to have you doing a high intensity exercise, that could potentially be a problem. And so that's kind of my thing on all of this. Okay. So just remember, this is HIPAA information, and we need people to be very, very honest so that we can keep them safe. Okay. So we talked about that. We talked about HIPAA. We talked about the PARQ. All right. Was this the version of the PARQ that I posted for you guys?
Yes.
Yes. Okay. So this one is technically, it came out in 2002. So it may have even, this questionnaire may even be older than some of you guys that are in class, which I find none of that to be okay. It makes me feel very old. There are several newer versions of the PARQ. They've come out with several different ones in the last couple of years, and they actually now have a PARQ that is basically a health screening questionnaire. But even the new ones are going to ask what is in essence kind of these initial sort of 7 kinds of questions. They're just very simple yes, no questions, okay? And the idea is that if you answer yes to any of these things, then you need to go to the doctor and have a physician sign off on it being safe for you to begin an exercise program or an increase in physical activity program, okay? And so it says something like, has your doctor ever said you have a heart condition and that you should only do physical activity that they recommend, okay? So you may have questions about this. I was diagnosed with a heart condition when I was born. I was born a month early, and I had a heart murmur when I was born. It has never ever been detected again since then, but I always have to try to disclose those things on medical history information. But I've never had a doctor tell me that it was in any way unsafe for me to be able to exercise because of all of that, okay? So you may say, well, what kinds of heart conditions? I don't know, but it's, it's the doctor said you've had something, okay? You can have high blood pressure and it can still generally be perfectly fine and safe for you to exercise. What we're thinking about is a valve disease, some kind of potentially conduction impairment, or an issue with stenosis in your aorta, or something, something like all of that, that's more kind of an anatomical pathology, okay? The second question is, do you feel pain in your chest when you do physical activity? Okay, they should be more precise in this. This is not pain that's like, hey, I'm doing bench press and my pec muscles hurt. This is really meant to be angina pain, okay? So this is kind of the hallmark way. The heart does not have afferent nociceptors, so the heart in and of itself cannot signal to your brain that it is in pain. And so it, in essence, borrows the nociceptors from some surrounding tissue. Nociceptors are nerve endings that generate pain. And so that's why you're going to feel it kind of in the left side in your neck and your arm and those things, okay? People that have had a heart attack recently, or that have like kind of severe narrowing in their coronary arteries, when they begin to exercise, that may bring on angina pain. We'll talk about that when we get into coronary artery disease, probably later today. But one of the things that happens is if you have mild to moderate coronary artery disease, mild to moderate blockage, you may only kind of begin to encounter problems once you make the heart work harder, which is going to be like during exercise or when you're super stressed or something, and your heart rate and your cardiac output goes up. So it may come on when you exercise, which is why we're asking this, okay? And then when you stop exercising, it may go away, okay? If you have more severe coronary artery disease and more severe blockage, then you may get chest pain at rest. If you're getting angina pain at rest, you need to go to the hospital like immediately, 10 minutes ago kind of thing, okay? Emma.
So I know that like I mentioned earlier, my dad had this like 98% blockage in what they call the widowmaker artery. And so, but he like had, I mean, no pain at all at rest. I don't even know if he had pain while he was exercising, which I guess is called the widowmaker. But do you know where it's like why it's called that? So do you know why it is like in that particular artery for some reason, like people just kind of stay asymptomatic?
I do not. No,
Okay.
I do not. I am aware sort of just exactly what you had said, that's what it is called, but that's the first that I am that's the first that I am hearing that it may, and it may sort of not cause symptoms consistently in a lot of people. I mean, there's a host of reasons why that might be the case, but I don't know off the top of my head. Okay. So then the next question is, in the past month, have you had chest pain when you're not doing physical activity? So as I said, during activity, you might be kind of mild to moderate blockage. You have it at rest, that's pretty severe blockage. Those are both not great things. Do you lose your balance because of dizziness, or do you ever lose consciousness? And so this could be maybe something as simple as you have orthostatic intolerance. And so when you have been sitting for a while and you stand up and you get a little bit dizzy when you first stand up, that happens a lot. That's why you're supposed to kind of not like immediately stop and sit down when you've been exercising pretty hard. Blood pools in the veins in your legs, and you have a little bit of trouble adjusting your blood pressure. But like if you ever like just sort of lose consciousness and black out, then that can be very indicative of impairments of blood flow to the brain. That can be really dangerous. It says, do you have a bone or a joint problem that could be made worse by changing your physical activity? This particular question on the newer forms has been made more specific. And you know, it is not just like, hey, yes, I had my ACL repaired 5 years ago or something. But it really is, it's kind of like the first question in the new ones. It says, like, do you have a bone or joint problem that a physician or orthopedic surgeon has said could be made worse by, you know, by a change in your physical activity, or that you need to modify your physical activity to prevent from it making worse? Is your doctor currently prescribing drugs for your blood pressure or a heart condition? If you have elevated blood pressure, if you're hypertensive enough that you're on a medication, a water pill, a beta blocker, an alpha blocker, an ACE inhibitor, or something like that. There's a host of things that you could potentially take. Then that probably is going to warrant going to the doctor to get checked out to make sure that it's okay for you to exercise. And then, do you know of any other reason for why you should not do physical activity? That one, there's a little bit of wiggle room in that, and it can't be that Dr. Black just hates exercising and so he doesn't want to do it. And he knows how the questionnaire works, and so I'm just going to answer yes. But essentially, if you answer yes to any of these, you have to go to your doctor, and the doctor has to sign off on you becoming more physically active. If you answer no to all of them, then we will consider you to be at a sort of relatively low risk for doing exercise that is going to be no more than brisk walking. Okay, so that's kind of how the PAR-Q works. So I'm not going to ask anybody to share. If you would like to share your answers on these kinds of things, okay? But my guess is that the statistics would tell us there's probably a couple of you in class that might have had a yes on one of these answers. And so we would then need to kind of further look into kind of what all is going on with you guys, and we might need to get physician's clearance for you to kind of do some sort of an activity increase. Okay, Aaron.
Okay, so I had a question on the PAR-Q, like when I was filling it out. This might be like, okay, I'm just gonna tell you like what I wrote for one.
Okay.
So it was the part where it was like, do you ever lose consciousness or do you lose your balance or anything?
Yeah.
Like a year and a half ago, I don't know if anyone else has like ever passed out before, but if you have passed out and like nobody could figure out why,
Yeah.
would you check yes? Or because I just put no because it was like a one-time thing, but I don't know.
So if you were coming, if you were going to come down and we were going to test you in the lab on those kinds of things, and that had happened to you, I would want you to put yes. And then we would try to have sort of further conversations about kind of what all was going on. And we might, you know, call the physician. I assume if that happened, that if they couldn't figure it out, you probably went to a doctor and they tried to figure it out or something. We would probably then try to call that particular physician or physicians and just get a thumbs up from them that they feel like that it is okay. Our philosophy, and I would encourage all of you guys, if y'all are ever doing these kinds of things, like if you're the person working, you know, as a personal trainer or a strength and conditioning specialist who has to sign off on these things, to always, 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 always err on the side of caution. If the worst thing that happens is it takes a couple of days to try to call and get someone's doctor on the phone, and investigate these kinds of things when the alternative is potentially you could go into cardiac arrest or have something really bad happen during a bout of exercise, then to me, that's a, that's the safest thing. But, as we talked about yesterday, my tolerance for risk is very low, and those kinds of things. But in this, also from a lab standpoint, like if we did something like that and didn't get all of that checked out, then and then something did happen, we could get into big trouble for those kinds of things. So if you ask me, like if I was just going to tell you whether or not it's safe for you to go exercise today, then the honest answer is I'm sure it's probably perfectly fine. Were you exercising? Do you mind me asking, were you exercising when you lost consciousness, or you were just there and you lost consciousness?
It was kind of weird. So like I'd never passed out before in my life, and then I went to take a shower and I passed out in the shower, and like I woke up on the floor of the bathroom.
Mhm.
But it was like a bad situation because I fell so far and I like my head bounced off the counter and everything. So I was like, okay, I'm gonna go see a doctor. But yeah,
You've been exercising before that?
no. So it was weird. It was just like it was a Saturday, so I probably hadn't exercised since like Wednesday or Thursday.
Okay, interesting. So, my wife has not ever actually lost consciousness doing things like this, but she has a level of orthostatic intolerance. Her blood pressure is good, but it's kind of low, which is in some ways relatively common, especially in some of you more sort of petite ladies, we will just say, in all of this. And she would have these things where we would go when we were like training for half marathons and marathons to walk, or on the race days when we would have done things. And if it had been hot out, she'd get a little bit dehydrated. And like, especially when she would get in the shower and it gets warm and you start shunting blood away from your internal organs and things out to your skin to try to dissipate heat, then all your tissues are competing, and so you have to be able to adjust your blood pressure to maintain flow to the brain and those kinds of things. And so she would get like dizzy, and then she would throw up and those kinds of things. And but it's kind of common after a lot of exercise. She dehydrated herself a little bit, already raised her core temperature, and so those kinds of things are probably more common than we would think. So that's kind of why I was asking that. Is there just some other reason? But some of it may just be that there was just some weirdness going on that day, Aaron. I don't know, but thank you for sharing. Okay, so we did this. We talked about this. All right, so now let's do the next kind of piece. Okay, so if the PAR-Q is good for light and moderate intensity activity, that's not what most people do, right? As we have learned with resistance training and with aerobic training, that the one thing that seems to be one of the best drivers of adaptations to increase our VO2 max, to increase our 1 rep max or our maximal strength, which are the things that seem to play a good role in providing these health benefits, right, and these longevity benefits, then we need to exercise at a higher and higher intensity, okay? It needs to be, at 60, 70, 80% of VO2 max, or 60, 70, 80% of 1 rep max. And so we're going to classify all of those things as vigorous intensity activity. So we need a more in-depth way of screening people, if that's our goal, to have them do that kind of stuff, just to make sure that we're identifying the proper amount of risk for them, okay? And so using that American Heart ACSM health screening questionnaire, we're going to perform something called a risk stratification, okay? And there is, in many ways, a flow chart or an algorithm that we're going to very closely follow based upon how they answer these kinds of questions, okay? So when we do this risk stratification, people get grouped into one of 3 categories. You're either considered low risk, moderate risk, or high risk, okay? If you are a high risk person, you need to go to see a physician to have them sign off on any kind of exercise, light, moderate, or vigorous intensity exercise. No matter what it is, you need to go to the doctor and get cleared, okay? If you're a moderate risk, then this is basically like a person that potentially could pass the PAR-Q, but has some other, especially behavior-related risk factors that we need to pay attention to. So if you're moderate risk, you can do light and moderate intensity physical activity. But if you're going to do anything that's vigorous, or we're going to do any sort of exercise testing, so like we're going to try to do a VO2 max test on you, even if it's a submaximal estimation protocol, we're going to try to assess your 1 rep max or something, you need to get physician's clearance, okay? And then if you're a low risk, then we think that it is reasonably safe for you to do basically anything, okay? Go run, go bike, go do your 1RM, whatever it is that we're going to do. You do not need physician's clearance, okay? And what you guys will find is that most of you all probably are going to fall into this low risk category. We see very, very few college-age individuals that are going to be high risk. And then the idea of moderate risk, we're going to have some people that are going to kind of be there in the middle, okay? Okay, so the first section of your questionnaires, if you guys have that questionnaire, you can pull it up and look at it, okay? The first section of that questionnaire is going to ask you questions about major chronic diseases. It's going to say, in essence, do you have a known and diagnosed cardiovascular disease, pulmonary disease, so something that has to do with your lungs, asthma, COPD, emphysema, cystic fibrosis, something like that, or a metabolic disorder. And the general metabolic disorder, the most common one that we're going to see in people, is diabetes, okay? There's going to be a few people that have some other much more rare metabolic disorders like Addison's or something like that. You may have people that have some sort of a thyroid issue that is maybe kind of not controlled with medication. That might be something that would fall in there. But generally what you're going to encounter with that one is going to be type 1 or type 2 diabetes, okay? We are going to screen for these kind of 3 major chronic diseases. If you answered, yes, I have something on any of these chronic diseases, you are considered a high-risk individual, okay? That's it. We're done. We don't even need to look at the rest of the questionnaire. So if you have one of these, you need to get physician's clearance before you do any kind of exercise, okay? Any kind of exercise. And what we have found is that generally, people that have these can relatively safely undertake exercise. They just may want you to start off kind of at lower intensity. The second portion of all of this, let's say you don't actually have a diagnosed disease. There's going to be questions about, do you display symptoms or signs of that particular disease, okay? That would let us know that maybe you have it, but it just hasn't been diagnosed yet. Although, to be honest, if you have these symptoms, then that's going to be part of the diagnosis the differential diagnosis that we make on things, okay? Those symptoms are going to be angina or pain with exertion, much like what we ask on the PAR-Q. Unusual shortness of breath at any time, okay? And so by unusual, it means like you're just sitting there and you're having a hard time catching your breath, okay? This happens to my wife sometimes. She has sort of a difficulty, we think, in her pulmonary system sometimes of adequately matching O2 use and CO2 production. And exercise seems to make it worse on like certain rare occasions. She's very unusual. The doctors, she's been checked out and nobody can ever figure out what's going on. But unusual shortness of breath is not, I just went and ran a bunch of wind sprints and I'm kind of out of breath from all of this. That's not unusual, that's expected, okay? Dizziness or syncope, which syncope is in essence dizziness that may lead you to faint, okay? And so again, we're kind of back to what Aaron had talked about. If you have either one of those 2 kinds of things, then we're going to consider you to be high risk, okay? Palpitations or heart palpitations, tachycardia, which is elevated heart rate or an irregular heart rhythm, that would be my heart murmur. In some ways that would fall under this, okay? And then unexplained ankle edema or what we call intermittent claudication. So both of these 2 things, unexplained ankle edema. This is not ankle edema because I'm pregnant. It's not ankle edema because I sat in a weird place and all the blood has kind of gone down to my ankles, and that's what's happening. Okay. This is a thing that doesn't resolve itself when you prop your feet up. It doesn't resolve yourself when you start walking around and things. So unexplained ankle edema, and then intermittent claudication is going to be pain, especially in your calves and in your feet, that seems to happen when you start undertaking kind of moderate to vigorous intensity physical activity. Both of these two things are going to be indicative of something we call peripheral arterial disease. And what that is going to entail is a lack of adequate blood flow to the muscles and the nervous tissue and things in your kind of lower extremities that tends to be made worse during a bout of exercise. Okay. Peripheral arterial disease, when you have unexplained ankle edema, you're getting venous pooling for a host of reasons. It could be indicative of a blood clot or something. And then intermittent claudication is much like having a heart attack. It's kind of the same pathology as having a heart attack. You're just having it in your foot or in your calf or something. If you experience any of these signs or symptoms, you're also considered to be high risk. Okay, you're also considered to be high risk. So basically, everything on that kind of front page of your health screening questionnaire is going to be things that if you answer yes to any of those, then you're considered high risk, and we need you to go to the doctor and get cleared before we do any kind of exercise or any kind of exercise testing. Okay. Let's say you don't have any signs or symptoms, and you don't have a diagnosed disease. So if that's going to be the case, then we are generally going to consider you to either be low risk or moderate risk. And the distinction between those two is going to be based upon these behavioral factors that you have that are contained in this particular chart. Okay, this particular chart. These things are classified as cardiovascular disease risk factors, or it's sometimes called atherosclerotic cardiovascular disease risk factors. Okay, these are things that are going to be indicative of the fact that you may have atherosclerosis and therefore very likely have coronary artery disease. So narrowing in the arteries that bring blood to your heart. Okay. Now, we're going to go through these, okay? But we're going to say age is going to be kind of a thing that is separate from these other 7, okay? And so there's a way that we look at your responses and then decide if you're low risk or moderate risk. Age is a little bit different, okay? So if we look at these things, if you are a man, say you passed the first part of the questionnaire, but you're a male who is 45 years old or older, or you're a female who is 55 years or older, then we consider you to be quote unquote high risk, and you have to get physician's clearance. Okay. It doesn't matter if you have none of these other risk factors, if you have no signs or symptoms and no diagnosed disease. Age all by itself can be a thing that we need you to go and get physician's clearance to begin exercising. Okay. I am rapidly approaching this particular age where I'm going to have that done. Okay, so age is separate. Age is separate. Assuming we are screening a man who's 44 or younger or a woman who's 54 or younger, we want to ask questions then about these other things. So I want you guys to look at how you answered these questions on your screening questionnaire. Okay, so the first one is about family history. Do you have a first-degree blood relative, mother, father, brother, sister, okay, who had a myocardial infarction, so they had a heart attack, had a coronary revascularization? This is what we're going to call the placement of a stent or some sort of coronary bypass surgery, okay, or had sudden cardiac arrest and death, okay, before the age of 55 in a father or a brother, or before the age of 65 in a mother or a sister. Okay, that's how we're going to say you have a family history of atherosclerotic cardiovascular disease. All right, don't get these ages confused with the ages here. Okay, Don't get them confused with the ages here. So if you have a male relative who had a heart attack before the age of 55 and a female relative who had a heart attack before the age of 65, that counts as a risk factor. Okay? Are you currently a cigarette smoker, or have you quit smoking in the previous 6 months? Okay. Now, I need to look this up. I think there is guidance in the new version of these things, but there is some guidance. You're going to ask, well, Dr. Black, how do I know if I'm a cigarette smoker? I might, on a weekend, smoke a cigarette when I go out with some of my friends, but that's pretty much it. I would say that doesn't really make you a cigarette smoker. But like if you smoke every day, there's a number of cigarettes that you have to smoke in a week that actually qualifies you as this. I need to go look that number up. But generally, people know if you're a smoker or not, or if you quit within the previous 6 months, or if you have some sort of prolonged environmental exposure to tobacco smoke, which at this point would mean that you live with a smoker who smokes inside, which is much more rare now than it used to be. Okay. Julia, did you have a question?
Yeah, regarding the smoking part of it, is it only smoking related to tobacco use? Like, for example, let's say that someone vapes, but there's no nicotine in it. That's not considered a risk factor?
Wait, so there are people that vape, they make vape that has no nicotine?
Yeah, yes.
Why would you do it if there's no nicotine?
I don't know, but there is.
We do not have any guidance yet on what to do about people that vape. My guess is that within the next 5 years or so, there will probably be some guidance, and I'm going to guess that we're going to consider people that vape to have a risk factor. Now, I'm not 100% certain if it is the presence of nicotine or if it is the chance that cigarette smoking is going to raise blood pressure because of the nicotine. It raises blood pressure, or may have some potential to cause, sort of lung impairment, pulmonary impairments, as to why it's exactly a risk factor. My guess is that mostly it's the smoking and the nicotine that's going to potentially lead to hypertension that may be there. So there's no guidance about vaping, even though I know that like vaping is the wild, wild west of things, that there's no regulation on how much nicotine can be in some of the vape stuff. So
is marijuana use also not considered here?
Correct.
Okay.
Correct. Although in our current sort of environment, at least in state, or any of you that want to go to Colorado or Washington or maybe Oregon or someplace where certain kinds of either medical or even recreational marijuana use is perfectly illegal, I don't really know why people would want to smoke the marijuana when you could just, have some gummies or something and avoid, the smoking is bad. Anything, burning of those things is going to get, kind of chemicals and stuff into your lungs in that period. But there's no guidance on marijuana, Julia. Okay. Although there is some fascinating evidence on having people exercise after they have had marijuana, and using some things like that. That's pretty interesting. Our next risk factor is a sedentary lifestyle. So if you do not participate in what is in essence 90 minutes of some sort of moderate intensity activity for the previous 3 months, we consider you to be sedentary. So you're less than 90 minutes a week of like walking. Pretty rare to see sedentary college students, but much more common in older folks. If you have a BMI over 30 or over, or a waist circumference that's greater than 40 in men, so this is measured right around your belly button. So waist circumference of greater than 40 in men or greater than 35 in women. So it can be either or of those two things. Then that's considered to be a risk factor. If you're hypertensive, so you have a blood pressure measured on at least 2 occasions under resting conditions where your systolic pressure is greater than or equal to 140, or your diastolic pressure is over 90, that's considered to be hypertension. It doesn't have to be both. It can be one or the other. The next two are going to be a little bit trickier for us. You get a lot of people that know their blood pressure or had their blood pressure taken much more often. But to try to identify if you are dyslipidemic or if you're a pre-diabetic requires blood and at least a finger stick at the very least. And so we're going to get a lot of people that don't know these two things. And so we're going to have to kind of make some inferences about these. But to be considered dyslipidemic, so this is basically means you have elevated cholesterol levels in your blood. You have to have an LDL cholesterol level over 130 milligrams per deciliter. Those units probably don't mean anything to you guys, but I do want you to memorize the value, please. So an LDL of greater than or equal to 130. LDL is considered bad cholesterol. HDL is good cholesterol, but so you have good cholesterol lower than 40, or a total cholesterol, which is these two things added together, greater than or equal to 200 milligrams per deciliter. Additionally, if you're taking a lipid-lowering medication, something like Lipitor or Crestor or something like that, which are two of the most commonly prescribed medications for sort of people over the age of 50, basically, then you're considered to be dyslipidemic. Some physicians now will actually, there's some guidance on using the ratio of HDL to LDL rather than using total cholesterol because there's some weirdness that goes into these things. So my mom, and this has happened consistently for like 30 years, my mom has very, very high total cholesterol, like total cholesterol over 300. But her HDL is like 150, and her LDL, right, is, or maybe her HDL is like 180, and her LDL is like, 125 or something. She has this really, really, really high levels of these things. And so some physicians now think it's the ratio of HDL to LDL, and that if we're in a place where basically your LDL is like 3.5 times or more greater than what your HDL is, then that's what's going to cause some problems potentially. Although from the ACSM standpoint, from our guidelines for deciding about exercise, that's not something that's not how we interpret the data. But I do just want to make you guys kind of aware that that is a way that some people are choosing to look at it. And at least that's what my mom's cardiologist had told us. Okay. And then to decide if you're a pre-diabetic, like if you are at a greater risk of developing type 2 diabetes, we need to understand something to see if you have something called impaired fasting glucose. So fasting glucose, we're going to quantify fasting glucose by getting blood from you first thing in the morning. Okay, you haven't eaten breakfast yet. You've been on an overnight fast of at least 8 hours. We get up and we see how much glucose is in your blood. And if we have an amount that is greater than 100 milligrams of glucose per deciliter, okay, but less than 126, that's considered to be impaired fasting glucose. If your fasting glucose is 126 or over, then you're a type 2 diabetic. And so what you guys want is for it to be under 100, okay? Now, if you took physiology here, you guys did something called a glucose tolerance test, where you had to drink a little kind of sugary drink, and then they drew blood from you probably every half an hour for maybe 2 hours or 3 hours while you were in lab. And we plot those things out and we calculate an area under the curve. And that's checking at how quickly your blood glucose goes up after ingesting a particular amount. And then it's also checking how quickly you can release insulin and then draw that glucose kind of back down towards baseline. And people that have impaired, that may be a diabetic, it's gonna go up higher and it's gonna stay elevated for longer than somebody that has normal sort of pancreas and insulin kind of sensitivity and insulin function. Okay. So both of these two things can be measured simply by getting a finger stick and getting blood. They can also both, like if you go to the doctor and they want to do a blood panel on you, As long as you haven't eaten anything kind of within the last maybe 2 hours or so, you can get reasonably okay kind of numbers on all of this. The last time I went to the doctor, it was like last year. I was sick and they wanted to do this on me, and because I hadn't had it done in a couple of years. And of course, I was like an hour after I had had Chick-fil-A for lunch. And they're like, yeah, your cholesterol's up. And I'm like, yeah, no shit, Sherlock. Um, we can't really understand anything from those particular measures. And they're like, oh yeah, and your glucose. I'm like, yes, my glucose is also up. And there's some better ways to look at this, and we'll talk about that when we get into diabetes. You can look at something called the hemoglobin A1C content, which is indicative. If it's elevated, that's indicative that you have elevated blood glucose levels over a much more prolonged period of time. And so then they, of course, sent my blood for further analysis, and my A1C was perfectly fine. And so they're like, okay, it's fine. Don't worry about anything. And I'm like, yeah, I tried to tell you guys this was not a good time to draw blood, but you all wanted it, so I gave it to you. Anyway, so that's kind of what we've got, okay? Don't worry about this thing as a negative risk factor, which means this would be good as if you have high serum HDL. We don't really use this anymore. But what you're going to look at then is these 7 risk factors, okay? If you have one of these risk factors or 0 of these risk factors, so look at what you guys put. If you have 1 or 0 of these, you're considered to be low risk, and you can do any kind of exercise that you want without physician's clearance. If you have 2 of these, or if you have all 7, it does not matter, okay? You can have 2 or you could have all 7, you're considered moderate risk, all right? I ask questions about all of this on the test every single semester. And someone says, oh yeah, like if I have 5 of these, I'm a high risk, and I get really upset. And the answer is no, 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 okay? If you get to this point, you cannot be high risk. You're either going to be low or you're going to be moderate, okay? So you would just count them up. All right, Nia.
So why would it not be high risk? Like if you had all 7?
I don't make those decisions, Nia. I just tell you about them.
Oh, okay.
So the honest answer is that what has happened is they have looked at data from hundreds of thousands of people, and they've made the determination that the risk of something happening based upon the number of these particular risk factors falls into a certain range. And even if you have all 7 of these, my guess is if you have all 7 of these things, then you probably have signs or symptoms or known, like diagnosed disease would be my guess. But that you're still, even if you have all 7, but you have no signs or symptoms and no diagnosis of a disease, you're going to still be at a markedly lower risk of having cardiac arrest during a bout of exercise. That's where they've arrived at how they've decided this. So that's the honest answer. I don't have a particularly good one on, like why is it 2 versus why is it 7? It's just that they've looked at all of the data and that's what it tells us.
So if you actually like get diagnosed with something, then you're high risk?
Correct.
Okay.
Correct. Like if you go to the doctor and they say you have coronary artery disease, or you have peripheral arterial disease, or you are a type 2 diabetic, right? Or you have emphysema, then you are high risk. Period. End of discussion.
Okay.
But to be honest, if you've got 2 of these and you're considered to be moderate, then all you can really do is go walk. And so you've got to go to the doctor if you're going to do what we typically would think of as a more traditional exercise program. And so in that particular way, we're mostly capturing kind of the things that would put you at greater risk anyway. And so that would be, that's also why it's maybe not the worst thing in the world to be moderate and not high.
Okay.
Excuse me. Emma.
So I feel like probably sort of in the general population, a lot of people like aren't aware of this, that like this thing exists, and that they should go to their doctor if they have 2 or more risk factors and whatnot before they start engaging in like truly vigorous activity.
Mm-hmm.
So I guess like my question is kind of like how high is the risk? And I assume that's going to vary based on, how many of these risk factors do you have and which ones do you have. And so like, I mean, your average Joe is just going to is just going to start going to the gym. And I assume that they're more or less okay.
Yeah. So, and I guess maybe I'd taken the slides out that had the numbers that, even if you have several of these risk factors, then you're at an increased risk, but it's still not, it's still like one in every 50,000 or one in every 10,000 or something like that, times that a person goes to exercise. So those are pretty good odds, right? That you're not going to have a cardiac arrest, in the midst of those kinds of things. So that's I mean the risk is still relative. Even if you've had a heart attack, then the risk is still pretty darn low that you're going to have another one when you go and exercise. Because now the standard of treatment is you've had a heart attack, we want you to go exercise. And so, and especially if we can get you kind of out of that acute phase in the weeks immediately afterwards, then you can do stuff unsupervised. You're probably still going to be perfectly fine. But like if you go to the Huff, I think you fill out the Part Q, but you don't have to do anything beyond that. It will be interesting to see in a couple of years if I have to go and actually go like bring some sort of physician's clearance for myself, that if they're doing the age thing on all of that, they make some other faculty and stuff do that. But generally we would tell people like just go and be symptom limited. Like if you don't feel great while you're exercising, then for God's sake, stop doing that and go to your doctor and those things. But that's kind of where we are. And the other piece of this too, though, right, is like, why do people not know this? Why do they not go to the doctor and get checked? Is because how many people don't have health insurance, and how many people, don't want to take the time to like, I gotta go, and they gotta go give blood, and then they gotta do the analysis, and my insurance isn't gonna cover that, and it's gonna be this, and then I gotta go back, and somebody's gotta read it, and I don't want to spend the, $300 or whatever it's going to be to kind of have these kinds of tests and things done. Because I don't have insurance, or I have crappy insurance and it won't cover it. So there's some definite implications of those kinds of things.
And I assume too that like if you had 2 or 3 of these and you went to the doctor and you're like, all right, like what should I do about exercise? I assume that like what they're probably going to tell you is that like you should just kind of start slow and then work your way up. Like
yes.
Okay.
The thought that a physician knows any more about exercise than like what you guys have already learned in the last like 2 weeks in class is ridiculous to me, because you can imagine a person that was maybe a biology major and then went to medical school and they talk a little bit about exercise responses. One of my former master's students is in medical school at Temple University in Philadelphia. And when they were taking several of their physiology classes, he would text me like 3 times a week and be like, they're getting this wrong. They're getting their exercise responses wrong. They're teaching this in the wrong way. Like they're not, they don't, the way they're teaching metabolism is, 50 years old and wrong and not under current understandings. And so, doctors, they learn a bunch of stuff. They have to cover a very wide range of things, and exercise is just not one of those. There are some medical schools now. There's a woman that was a PhD student with me at Georgia, and she works at the University of South Carolina at Greenville in their medical school. And she is like, part of their program is to teach the doctors about public health and the value of exercise sort of as a treatment for things. But they are very much in the minority. If you were to ask me, every doctor's office, every hospital, everywhere should have an exercise physiologist and kind of a behavior person. They're now getting where they have people to do nutrition. Like they should just have people that do this to like, okay, well, we think you need to start exercising. Go down and see our person, and they'll help you get on a plan or find a plan or tell you what you can and you can't do and kind of what's safe. In the same way that they're like, okay, well, we think you need to lose weight, go see our nutritionist or something, and and do those kinds of things. But again, we've not really made kind of a big push like we've already talked about, right? That, you know, being sedentary is the second leading preventable cause of death behind cigarette smoking, and you see all kinds of things about, you know, smoking being bad, and even now some commercials on vaping being bad. You never see commercials about, hey, get off your ass and go exercise. So anyway, I'll get off my high horse again, but yes, you are right. You'll go to a physician and they'll probably tell you, you would be good for you to exercise, go do a couple of days per week, and, you know, maybe start off with some walking and try to work your way up in intensity and those kinds of things. Yes. Or they'll say, go join a gym or, you know, something. So Wyatt.
Yeah, so I know this is like depends obviously on a case by case basis, but I've read some stuff about where they recommend like exercise for cancer patients because it does help in some sense. So I didn't know if that would count as like a high risk because they do have a diagnosis of cancer. I just didn't know.
That would be my guess. Well, I say that. Probably, well, so having, okay, there's going to be some nuance in this answer. So generally, my guess is that if you have cancer and you're currently undergoing treatment, right? If you're on chemo or you're on radiation, I would want physician's clearance to do those things because we know that the chemo and the radiation can have some kind of very marked effects on the cardiovascular system. One of the big side effects of those kinds of things is it causes damage to capillaries and may lead to kind of impairments in coronary artery function, which is a big thing that people are interested in now. It doesn't do us any good that we can have better cancer treatments and people can survive their cancer for longer if the treatment for it basically gives them cardiovascular disease and then they die from a heart attack. That's not what we want. But if you have, you know, I don't know, if you're not undergoing kind of treatment currently or something in there, they're kind of looking at stuff, or you've just had surgery or something, then, I mean, having the cancer all by itself may not necessarily raise your risk of having a cardiovascular problem or a pulmonary problem if the cancer, like if you have lung cancer, that's one thing, but, you know, you have a woman that has breast cancer or a man that has prostate cancer and they're not actively getting radiation or chemo, then I don't know that those things are going to have any kind of real effects that we would want to worry about in the cardiovascular system or the metabolic system or the pulmonary system. And so it would probably be perfectly fine to have them, as long as they pass this other portion of things here, probably be perfectly fine for them to do any kind of exercise that's out there. I never really thought about that, Wyatt. No one's ever asked me that question. So that's good. I like it. Okay. So guys, let's take a break. Okay. And when we come back, what I'm going to do is I'm going to put you guys into some groups and let you work through a couple of case studies on these things, and we'll talk about that and go from there. Let you guys practice how we put all of this into use, and it will raise a couple of circumstances that we haven't talked about yet that I think will be interesting. Okay. So I'm going to stop sharing. We're going to get into groups in breakout rooms, and you're going to need to have your PowerPoint available. And so what we're going to do is we're going to go down, and starting on slide number 22, there's 3 different case studies. Okay. Now, I've taken these case studies out of an older version of one of the ACSM's health and fitness kind of manuals, and they're meant for practice things, okay? They also have been designed to look like things that you might get or see from an individual who maybe has not been the most forthcoming or maybe has not done the world's kind of greatest job of filling out the questionnaire. So it may not be the absolute most straightforward kind of way of looking at things, not laid out just like what we went over, okay? And so in that way, it's meant to kind of mimic the real world. So what we're gonna do, I'm gonna put you guys in your rooms, and then I want you all to go and try to read through it and chat. And then when you're done, come back here to the middle and I want you to type into the chat room what you felt like their risk stratification. They're either going to be low risk, moderate risk, or high risk. Okay. All right. So I'm going to. So we've got this for the folks that aren't here. So I'll just pick one of the groups, and you guys can tell me kind of why you got what it was that you got. So we will pick. So Gabby, we'll pick y'all's group since y'all were at the very last one the kind of one that I see here. So Gabby, Shakota, and Nia, you guys said low risk. So to be, let's reiterate, to be low risk, what do I need to like have going on? Like what makes me low risk?
0 to 1.
Okay.
0
to
positive
1.
factors.
Okay. So you guys thought she had 0 or 1 risk factor. So tell me what you thought her where she was.
Just her smoking was a risk factor.
Just smoking. Okay. So as we walk through our other ones, let's kind of check these kinds of things off. I'm going to go back to my list. So age-wise, you guys think she's okay?
Yes.
Okay. We've got smoking. Do we think she's sedentary or not?
She is not, right?
Why did you make that decision? Or we can ask one of the other groups. Maybe does anybody else? They might think there's a reason to question if she's sedentary or not.
She's not. She attends group exercise class 2 to 3 times a week.
Okay.
Yeah, so assuming that group exercise class is like longer than is about 20 or 30 minutes.
Uh-huh.
Not sedentary.
Okay. Do you guys think she might do any other physical activity during her week, or it's only ever all she ever gets is when she goes to group exercise class? Like, is there a way you could go twice a week to a 30-minute group exercise class and like just do crunches and those kinds of things and still end up being sedentary?
Yes.
It's very unlikely, but there's maybe a chance, right? There's maybe a chance. So I would agree with you guys that the most likely scenario out of all of this is that she's not sedentary. Okay, because we haven't asked any information about like, do you walk around at work, or do you do anything else where do you have a pet or a dog that you walk, or like do you do anything else that would get you some level of physical activity? And most people get a little bit of something. And if she's going to the group exercise classes and she's close because of that, right? Then we're probably there. But you could make an argument, right, if you wanted to, that she doesn't get enough, or that we don't have enough information for that to be able to say with any level of certainty. And if we don't know something, we should probably count it as a risk factor. Okay, so we go either way. But I would tend to agree with you guys that she's probably not sedentary. Okay. What about obesity? What's her BMI? Was she okay by BMI?
Yeah, she was fine with BMI because it has to be more than 30, right?
Right, got to be 30 or more. Okay. What about blood pressure? How's her blood pressure?
That was fine.
Her blood pressure is fine. Okay. What about her blood cholesterol levels?
That was also good.
Good.
Those were also good. Okay. And then what about fasting blood glucose?
It was unknown.
It's unknown. So what do we do with that? We don't know it. So how should we treat that?
Should we treat it if it's unknown? Should we go based off of her parents' history of health?
So does it say if her parents are diabetics?
No, it says both parents living and in good health.
Okay. I mean, that's good. That's a reasonable kind of thing. But so how do you guys think we should approach that? Because this is going to be a thing that we encounter very, very often, right? Is where I don't have information on a person's fasting blood glucose.
I would say, did your physician clear you or anything like that?
Okay.
Or have you gotten I don't know.
No, that's okay, Simmons, because we're kind of in the point of deciding if they need to go back to their physician. You know, that the physician may have even told you it was okay to exercise and you know, not really pay that close of attention to those things without getting that data. So the reason, so the answer that we're gonna end up with is that I would agree with all of you guys that said that she's low risk. Okay. Now, what we're supposed to do is, if we don't know an answer to a question, we don't have enough information, we treat that as a risk factor. We're better to be safe than to be sorry. However, one of the ones that we very often don't know is the one about fasting blood glucose. And so what happens generally is, if the person is not sedentary, okay, and they aren't obese, and they don't have a parent that is a type 2 diabetic, then we tend to not count it as a risk factor. Although, to be honest, it doesn't really matter, because if they were sedentary and they're obese, who cares if we know they're fasting blood glucose or not? You're going to be a moderate risk. And so it doesn't really change us in one way or the other. But that is how the sort of book and things are laid out to try to get at all of this. Is that if you're not obese and you're not sedentary and there's no family risk, no family history, then we don't count that as a risk factor if we don't know it. Okay. Okay, so my group that said that you thought she was moderate, so Araceli, Cindy, and Jessica, you said she smokes a lot and she has a pretty high heart rate for a 21-year-old. So at 76 beats per minute, having seen what most of you guys have as resting heart rates, I'm not 100% sure that that's super duper high, but was that, so did you think, is that a risk factor, having a high resting heart rate?
To me, that kind of pointed towards a more sedentary lifestyle for her age.
Okay.
But that was kind of my reasoning behind that.
Okay, well, I would agree, Jessica, that you're thinking about that correctly. If you are, the more sedentary you are, you're very likely to have a higher resting heart rate. But we have to be very careful about these kinds of things. And this is why I like for us to kind of talk about these as a group and do all of this, is that you're absolutely thinking about that correctly. However, we are, for better or worse, bounded in our decisions by the guidelines and the questions that have been set out for us in those things, okay? And so, you know, we can say, well, it kind of looks like this or it kind of looks like that. We have to go by, for making our decisions on that, resting heart rate is not something on which we're allowed to base. You know, that's not a specific risk factor. And so we can make note of it, right, and think about that as we were to look at things, but then from there, we're not gonna, we can't make a decision. Okay, so, but if we did think that that was a thing, then with 2, she would absolutely be moderate. Okay, so that's kind of how we're approaching all of that. Does that make sense, everybody? Okay, all right. Then what we're gonna do is we're gonna do the next one. Okay, we're gonna do number 2. And I don't know what's going to happen. I don't know if it's going to put you guys back in the same breakout rooms.
Oh, since we're only doing like 2 of the case studies, I have a question about number 4. Just, just
okay.
So we decided that it would be high risk because she has been diagnosed with diabetes.
Mm-hmm. Yes.
But we didn't know if it had to be like type 2 diabetes.
No. Either type 1 or type 2 diabetes. If you're a diabetic, you're high risk.
Okay.
Done. End of story. Okay. Low risk, moderate risk, low risk, high risk due to age. Uh-oh, is Germany going to score? Oh, the guy missed it. Ooh, they had a breakaway. All right, high risk, low risk, moderate risk, and we're still waiting for a couple of other groups to put theirs in there. So we're kind of all over the place. Let's start with Chandler. You guys say moderate risk. Why?
Because his age, since he's 54, it automatically puts him in the moderate risk category. And then he had no other issues besides a slightly high blood pressure and family history. But when you look back at the table, his parents didn't die before that set age, so we didn't count it.
Okay. It occurs to me that I think I misspoke earlier when I talked about how we treat the age sort of thing. I think I told you guys that makes you high risk rather than making you moderate risk. And so what we do is, if you don't have any signs or symptoms, so what you guys put is correct, Chandler. Okay. But I misspoke, and that may be why, like that, Sunny and Emma and Savannah, you guys put high risk. I think I said that you are high risk, but what I really was meaning is you have to get physician's clearance, but it's just to do the vigorous intensity activity. Because if you don't have any signs or symptoms, you don't have a known disease, that's the only way you're going to be high risk. So I apologize that I think I misspoke on all of that. So Chandler, what you guys did is right. So 2 should have been really easy. You guys read to like the end of like the first line, and that's it. We've got the age thing. They got to go to the doctor to get those things kind of taken care of. And so then that would make them that way. So Madison and Blake and Jacob, you guys put low risk for everything. I assume that was because like he doesn't have any risk factors, right? There's nothing else that's going on there. Is that what you guys were thinking on that?
I just couldn't remember. I like wrote down that you said high risk for age, and then Blake was like, "Oh no, I think it's low risk." And so then we were just like, "Well, I don't know like what it is." So we're just like, "We'll just put one like low because it's like only one of them."
Yeah.
So because I wrote down high risk, so
okay.
Yeah, we were just kind of confused on that, but we knew the age was like a thing.
Yeah, no, that's great. That's great. So see, here I am confusing you guys in the midst of all of this, but that's okay. I appreciate, the educational research tells us that we learn and remember better when we get things wrong. Like you'll always remember the question you got wrong and rarely ever remember all the questions that you got right, which is interesting to me. I guess that's an evolutionary thing. Like we always remember the stuff that went badly so that we don't do that again. That snake bit me, so stay away from that snake, types of things. So, okay. So that's right. So that's how we would want to handle that one, is that he is going to be, he's going to be moderate risk because of what all's going on there. Okay. And my guess is that if you were to look at that person, even based upon their age, if they don't have any of the other risk factors, they're going to go to the doctor and they're going to be fine, right? Like it's not going to be a problem for them to do everything. We just want to be very, very careful and make sure that we get clearance on everything. Okay. So Emma had a question and Nia had a question. I do not recall who had their little wave at me thing up first. So either one of you can just yell at me and we'll go from there.
I guess I just wanted to clarify. So like age automatically makes them moderate risk, even if that's like their only risk factor?
Correct.
Okay,
Correct.
but it doesn't automatically make them high.
Correct, which I think I said high when we were going through the slide, and I just misspoke on all of that.
Okay, so even if that's their only risk factor, that automatically makes them
moderate.
Okay.
That's correct. That's correct.
So they don't need, because I remember you said it had to be like 2 to 7 to make them moderate. So their age automatically just makes them moderate.
Age is sort of held separate from the other 7. Okay. So if you don't have any signs or symptoms and you don't have a known disease, but you're a guy who's 45 or older or a girl who's 55 or older, you're just moderate risk. It doesn't matter what the rest of the risk factors say or what goes on in that. There's no part of that matters. Okay. Okay. Very good. John, you're behind me on whatever you're watching. So, in those kinds of things. Okay. All right. I know we're falling sort of slightly more behind, but do you guys, let's just stop here. This is fine. And there's no reason for us to do 10 minutes of cardiovascular disease only to have to like pick it up again tomorrow with everything. Okay. So what I want to do is, it will save the chat thing for me. Okay, never mind. I'm going to be good. We're going to be good. Okay, there we have it. That's what I need. Sorry, I'm just kind of now talking to myself to record this so people that aren't here. You're also going to make a scatter plot for the lab. And once you make the scatter plot, you're going to plot basically resting heart rate on the x-axis, and you're going to plot predicted VO2 max on the y-axis. And then you make that scatter plot, and if you're in Excel, you're going to right-click on the little dot. So each person is going to be represented by a dot on your scatter plot. And so that dot is going to occur wherever your heart rate and VO2 sort of would match up on the graph. You're going to right-click on the dots, and you're going to add a trend line, is what it's called. And it's going to be a linear trend line, and it's going to give you something that's called an R-squared value. And that's going to tell you basically the strength of the relationship, like how much of a kind of straight line of best fit would go through everybody's data points. So it's a way of us to try to decide how useful would, say, resting heart rate be at predicting for us differences in people's estimated VO2s. And I think that's what I'm trying to pull up the lab and look, but I think that's the only one that I'm going to have you do a scatter graph for when we do the body comp, when you're going to make several kinds of scatter graphs. So graphs, yeah, make a bar graph, class average for men, women, and you for resting heart rate, distance walked in the 6-meter test, and estimated VO2. So bar graph, 3 bar graphs, one for each of those, Aaron, and then a scatter graph, heart rate on the x-axis, estimated VO2 max on the y-axis. You want to put in a plot of the line of best fit, and then it's going to display the R-squared value. Okay?
Sounds good. Thank you.
You got it. Has anybody taken the class that I think it's offered in the business school? It's like a 1-hour class, but they teach you how to use Excel and like how to make graphs and how to do calculations and a bunch of things.
No, I just use my mother for that, who's a professional accountant and therefore knows Excel inside and out.
I also use my husband, who his work uses Excel. So I'm like, help me make this graph.
Y'all are doing those things. Okay.
In biology, like Bio 1, I remember everyone was struggling because we had never used Excel before, and they were just like, make this graph, due on the first day of class. So that's kind of how we learned.
That was my first exposure to Excel as well, was like they gave us some data and we're like, here, do this. And I'm like, I have no idea. And that was, in like 1998. And so like YouTube was not a thing. Like you couldn't just Google things. You could try to like Yahoo stuff. But you couldn't just go